Welcome to This Week in Surgery. This week we're covering 10 notable papers spanning advancements in minimally invasive and robotic surgery, optimization of colorectal cancer and pelvic pathology management, and critical updates in oncologic staging and prognostication. Let's dive in. We begin this week by looking at how minimally invasive and robotic platforms are expanding across diverse surgical specialties, from breast reconstruction to foregut and biliary procedures. In the realm of breast surgery, the Annals of Surgical Oncology published a prospective, multi-center randomized controlled trial evaluating the safety and effectiveness of robotic-assisted nipple-sparing mastectomy using the Da Vinci single-port system compared with open mastectomy. Conducted across 14 United States sites by 23 surgeons, the study randomized women with early-stage breast cancer to either the robotic approach or open surgery, both followed by immediate implant-based reconstruction. Out of 74 patients completing surgery, totaling 65 robotic and 66 open procedures, the researchers found that the robotic approach was highly feasible, with no conversions to open surgery. Although the robotic group experienced longer operative times, averaging roughly 142 minutes compared to 84 minutes in the open group, safety profiles were comparable. Serious adverse events occurred in 3 robotic patients and 8 open surgery patients, with no device-related serious adverse events reported. Viability of the nipple areolar complex at 42 days was nearly identical, and positive surgical margin rates were exactly the same. While patient-reported outcomes via the Breast-Q survey favored the robotic approach in multiple domains, these differences did not reach statistical significance. This trial suggests that single-port robotic mastectomy is a safe option for early-stage breast cancer, with the longer operative times likely reflecting early clinical experience. Moving from the breast to the biliary tree, a retrospective study from surgical endoscopy evaluated robotic versus laparoscopic common bile duct exploration within a high-volume specialist unit. Analyzing 547 patients, of whom 498 underwent laparoscopic and 49 underwent robotic exploration, the authors found that complete bile duct clearance was achieved in 99% of laparoscopic and 100% of robotic cases. Retained stones occurred in 3% of the laparoscopic group and 2% of the robotic group, which was not a statistically significant difference. Similar to the breast trial, the robotic approach was associated with a longer median operative time of 156 minutes compared to 140 minutes for laparoscopy. However, major morbidity, bile leaks, readmissions, and hospital lengths of stay were comparable between the groups, even after adjusting for baseline differences using inverse probability of treatment weighting. While laparoscopy remains the standard, the robotic platform appears to be a safe alternative that may offer technical advantages in complex, demanding cases. Continuing with robotic applications in the upper abdomen, another study in surgical endoscopy systematically reviewed the predictors of 5-year revision surgery after robotic hiatal hernia repair. Analyzing 15 studies representing 14 independent patient cohorts, the investigators found that the overall recurrence rate ranged from 5% to 15%, with a weighted average 5-year revision rate of approximately 2%. Crucially, hernia size emerged as the strongest predictor of recurrence and revision. For small to medium hernias under 5 centimeters, revision rates were low, ranging from 0% to 2%. However, for large hernias between 5 and 10 centimeters, revision rates rose to between 5% and 12%, and for giant hernias with over 50% intrathoracic stomach migration, revision rates escalated to between 15% and 30%. The use of mesh reinforcement appeared to lower revision rates to between 2% and 4%, compared to 6% to 8% for non-mesh repairs, though significant reporting heterogeneity prevented a formal meta-analysis. These findings highlight the need for careful patient selection and technical optimization, particularly when addressing large or giant hiatal hernias. Next, we turn our attention to colorectal surgery, examining new data on advanced malignancies, metastatic disease, and pelvic floor pathology. We start with the management of advanced primary colorectal disease. In the diseases of the colon and rectum, researchers presented the 3-year follow-up of the JCOG 1107 trial, a multi-center randomized phase 3 trial in Japan comparing laparoscopic and open primary tumor resection in patients with symptomatic, non-curable stage IV colon cancer. Among 195 randomized patients, laparoscopic surgery was confirmed to be non-inferior to open surgery. The 3-year progression-free survival was 0% in the laparoscopic group and 3% in the open group, meeting the pre-specified non-inferiority margin. 3-year overall survival was also comparable at 28.5% for laparoscopic surgery and 31.5% for open surgery, and late major complications were rare in both groups. This long-term follow-up solidifies laparoscopic primary tumor resection as an acceptable and safe option for patients requiring palliative resection of symptomatic stage IV colon cancer. When colorectal cancer metastasizes to the liver, surgical and systemic strategies must be carefully coordinated. The Annals of Surgical Oncology published an individual patient data network meta-analysis of 7 randomized controlled trials involving over 1,300 patients with initially unresectable colorectal liver metastases. The analysis compared different induction chemotherapy regimens to determine the best balance of efficacy and safety. While adding bevacizumab to triplet chemotherapy offered the highest probability of improving progression-free survival and achieving successful R0 or R1 surgical resection, it also carried significant toxicity. Ultimately, the combination of bevacizumab with doublet chemotherapy demonstrated the most balanced benefit-risk profile, making it a highly reasonable compromise for most patients. However, tumor biology remains key. For patients with coarse or BRAF wild-type tumors, cetuximab plus doublet chemotherapy was the only regimen that significantly prolonged progression-free survival compared to chemotherapy alone, whereas those with mutant tumors derived the greatest benefit from bevacizumab plus triplet chemotherapy. For patients with small colorectal liver metastases of 3 centimeters or less, a systematic review and meta-analysis in surgical endoscopy compared the outcomes of thermal ablation versus liver resection, pooling data from 1 randomized controlled trial and 6 propensity score-matched or target trial emulation studies. The authors found no statistically significant differences in overall survival or disease-free survival between the 2 modalities. However, thermal ablation was associated with a dramatic reduction in complications, cutting the risk of overall complications by more than half and major complications by nearly 2/3 compared to surgical resection. This suggests that for small liver metastases, thermal ablation is a highly effective, lower-risk alternative that should be discussed in multidisciplinary team meetings. For patients with peritoneal carcinomatosis from colorectal cancer, a critical and often underappreciated question is the management of the ovaries during cytoreductive surgery. A retrospective study in the Annals of Surgical Oncology analyzed 74 female patients undergoing curative intent cytoreduction. The findings were stark. 79% of the patients had pathologically confirmed ovarian metastases. Even among the 16 patients with normal-appearing ovaries who underwent oophorectomy, 25% had microscopic ovarian metastases. Furthermore, among the small group of patients who had normal-appearing ovaries preserved during surgery, 40% experienced a recurrence in the ovaries within just 15 months. These high rates of occult disease and rapid recurrence strongly support the practice of routine bilateral salpingo-oophorectomy during cytoreductive surgery, even when the ovaries appear macroscopically normal. Finally, shifting from oncologic colorectal surgery to pelvic floor pathology, we must consider how the urgency of presentation affects outcomes in rectal prolapse repair. An analysis of the American College of Surgeons National Surgical Quality Improvement Program database. 000 patients undergoing elective versus non-elective rectal prolapse repair. Non-elective cases made up about 9% of the cohort, and these patients were significantly older, more functionally dependent, and more likely to undergo a perineal approach. Even after adjusting for these baseline differences, non-elective surgery was independently associated with a doubled risk of 30-day postoperative morbidity, a nearly tripled risk of mortality, and significantly higher rates of reoperation and unplanned readmission. Within the non-elective group, patients undergoing emergent surgery faced an even higher mortality rate of over 6% compared to roughly 3% for non-emergent urgent cases. These findings emphasize the importance of timely elective repair to avoid the severe risks associated with acute, non-elective presentations. Our third theme focuses on refining how we stage and prognosticate complex malignancies, moving beyond traditional, rigid classification systems to improve surgical planning. In breast cancer staging, the current American Joint Committee on Cancer System defines clinical N1 status by node mobility rather than the number of involved nodes. A study in the Annals of Surgical Oncology evaluated 618 patients with biopsy-proven nodal disease who received neoadjuvant chemotherapy, comparing those with 1 to 3 mobile nodes to those with 4 or more mobile nodes on pretreatment imaging. The researchers found that patients with 4 or more mobile nodes had a significantly higher burden of residual nodal disease after chemotherapy and were nearly twice as likely to be pathologically upstaged to YPN2 or higher compared to those with fewer involved nodes. In fact, their pathologic outcomes closely mirrored those of patients presenting with matted, clinically N2A nodes. This suggests that imaging-defined nodal burden should be incorporated into clinical staging to better guide neoadjuvant therapy, surgical planning, and clinical trial eligibility. Similarly, in hepatobiliary surgery, relying purely on anatomical definitions can fail to capture the true oncologic risk. A study in the Annals of Surgical Oncology proposed a new staging framework for perihillar cholangiocarcinoma. Traditionally, borderline resectability has been defined anatomically by vascular involvement or bismuth-type IV disease. However, in this multi-institutional study of 239 patients, anatomical definition alone failed to stratify recurrence-free or overall survival. By incorporating a biological marker, specifically a carbohydrate antigen 19-9 cutoff of 200 units per milliliter, the authors created a 3-tier anatomic biologic borderline resectable framework. This integrated system successfully stratified 2-year recurrence-free survival, which was 55, 7% in the low-risk group, 37, 8% in the intermediate risk group, and 25, 3% in the high-risk group. After multivariable adjustment, the high-risk group carried a nearly doubled hazard of recurrence or death, demonstrating that incorporating tumor biology significantly improves our ability to select patients who will truly benefit from upfront resection. If you only have time for one paper this week, make it the retrospective study by Morgan and colleagues in the Annals of Surgical Oncology on the risk of ovarian metastasis in colorectal cancer-related carcinomatosis. This study provides a clear, practice-changing message for any surgeon performing cytoreductive surgery. Given that a quarter of normal-appearing ovaries harbored microscopic metastases and 40% of preserved normal ovaries recurred rapidly, routine bilateral salpingo-oophorectomy should be strongly considered for all female patients undergoing curative intent cytoreduction. Here are the key takeaways from this week in surgery. First, for patients with early-stage breast cancer, robotic-assisted nipple-sparing mastectomy using a single-port system is safe and feasible, offering comparable margin status and complication rates to open surgery, though it requires longer operative times. Second, in patients with non-curable stage IV colon cancer, laparoscopic primary tumor resection is non-inferior to open surgery and remains an acceptable option for managing symptoms like bleeding or obstruction. Third, when treating initially unresectable colorectal liver metastases, bevacizumab plus doublet chemotherapy offers the most balanced benefit-risk profile, while thermal ablation is a safer alternative to resection for metastases 3 centimeters or smaller, with equivalent survival outcomes. Fourth, during cytoreductive surgery for colorectal carcinomatosis, visual inspection of the ovaries is highly unreliable, meaning routine bilateral salpingo-oophorectomy is warranted to prevent rapid recurrence. Finally, clinical nodal staging in breast cancer should consider the number of suspicious lymph nodes on pretreatment imaging, as patients with 4 or more mobile nodes have a significantly higher risk of pathologic upstaging after neoadjuvant chemotherapy, similar to those with matted nodes. That's your roundup for this week in surgery. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.